Morning, everyone. It's my honor to be here to share my presentation, my clinical experience. I'd like to talk about the LBBAP, LBBP, and the LBSP effect compared with BIVP. First, let's see the effect of LBBAP CRT in patients with heart failure. Now we know the LBBAP include select LBBP, non-select LBBP, and LBSP. This our first study to confirm the LBBP code has achieved the LV synchrony in patients with narrow pairs. And we also found the LBBAP could correct the bundle branch block, like the left bundle branch block and also right bundle branch block. The observational study have reported the effect of LBBAP in patients with heart failure. Several lots of observational studies have showed their significant improvement in LVEF in patients with heart failure. And also the LBBP could have achieved 100% super response in patients with LBBB-induced cardiomyopathy. That means the LBBP could correct LBBB and then correct the LV dysfunction. Also, some studies have showed the LBBAP could improve the LVEF in patients with pacing-induced myocardium. And Professor Zhou and our team have cooperated to see the LBBP have a good effect in patients with mildly reduced ejection fraction and left bundle branch block. These studies showed the effect of LBBAP. How about the different effect of LBBAP versus BIVP? This is our the first study in our team. We reported this study in 2020. We firstly compared the effect of LBBAP and with the patients received BIVP. In this study, we found the LBBAP could achieve higher super response when compared with the BIVP. This study is the first RCT. Professor Joe and our team performed this small RCT, only used 40 patients with NICM and complete left bundle branch block. And this study showed the LBBP could achieve a higher or better response, a better effect in improvement of LVF. In this study, our two team have confirmed each person with successful LBBP, not LBBAP. So in this group, we can see the better effect of LBBP. The long-term clinical outcomes of LBBAP have also been reported compared with the BIVP, and we can see the LBBAP could have the better long-term clinical results like the death and heart failure, hospitalization. And also the LBBAP could achieve a less arrhythmia risk compared with BIVP. These studies just show the better effect of LBBAP versus BIVP. How about the effect of LVSP and LBBP? Because we know the LBBAP include LVSP and LBBP. In clinical practice, many of patients, in fact, they just achieve the LVSP, not LBBP. We need to confirm uh, the capture of LBBP. Like this ECG, we can see for this figure, you can see the the similar caries morphology and the narrow caries. However, you can see this paced caries have a longer LVAT, but for LBBP, the caries have a shorter LVAT and also the RBB morphology. The effect of LVSP and LBBP might be different. This study shows the shorter LVAT and the deeper lead, lead position. And for the effect of LBBP and or LVSP on LV synchrony, you can see in this study they showed better LV synchrony in patients with LBBP, but for LVSP, the red line, the LV synchrony is worse than LBBP. This study also showed the electrical synchrony and mechanical synchrony between LBBP and LVSP. It seemed the mechanical synchrony is similar between two groups, but the electrical synchrony is different between LVSP and LBBP. This just the electrical and mechanical LV synchrony between LVSP and LBBP. How about the effect of LVSP and LBBP on the clinical results? Yeah, the Professor Zhou and our team also performed this prospective observational study. All patients have the long follow-up duration over than 24 months. And the primary outcome was the composite of heart failure, hospitalization, and all-cause mortality. We want to confirm maybe the effect of LVSP and LBBP might be different when they compared with BIVP. Let's see the primary outcome. We can see the LBBP have the best clinical outcome, but the BIVP and the LVSP have similar clinical outcome. When we see the when we combined the LBBP and the LVSP as a group of LBBAP, in the previous studies of LBBAP and BIVP, they showed LBBP have a better effect, but they don't know whether the better effect come from the LBBP or LVSP. So we combined the LBBP and the LVSP as a LBBAP. We can see the similar effect to the previous studies. But when we divided the three groups, we can see the effect are different. The LVSP had a similar effect to BIVP when we compared the primary outcome. When we see the secondary outcome, the risk of heart failure rehospitalization, it seems the LVSP had the similar effect to BIVP. But when we see the all-cause mortality, the all-cause mortality is highest in patients with LVSP when they compared with BIVP and LBBP. In the three groups, LBBP had the best effect on all-cause mortality and the heart failure hospitalization, but the LBSP had a higher risk of all-cause mortality than BIVP. These results give us more uh, insight into the effect on different pacing strategies. So, in clinical practice, how should we choose the pacing strategy in patients with heart failure and the left bundle branch block? Another study also showed the similar results as our study. They also compared the patients with LBBP, LBSP, and BIVP. And the primary outcome include heart failure, hospitalization, and all-cause mortality. The result is also similar. LBSP had the similar result with to BIVP, and the LBBP had the best result when compared with other pacing strategies. But we can see they just compared the heart failure hospitalization. They did not compare the mortality. I think the mortality might be the most important clinical outcomes for patients with heart failure. This year, we can see just the study, they see the new onset left ventricular dysfunction after LBBP. At least they think their patients all successful left bundle branch pacing, not left bundle branch area pacing. So after the follow-up of a mean follow-up of 28 months, they have 75% patients have the new onset left ventricular dysfunction. When they see the the cause of the new onset LV dysfunction, they found the loss of conduction system capture is the main risk factor. That means if the left bundle branch capture was lost, the LV function will be decreased. In these patients, they have 6 patients to receive the re-intervention to reposition the lead to capture the left bundle branch. So you can see even in patients with baseline normal LV function, after the re-intervention of LBBP, the LV dysfunction was improved in this patient. And in patients with recovered LV function, that means in their baseline LV dysfunction and was corrected by LBBP, but the loss of LBB capture caused the LV re-dysfunction. So after the re-intervention, the LV function was re-normalization. In summary, I think after review these studies and combined our clinical practice, we think the LBBP and the LBSP show the different electrical physiological LV synchrony. In fact, actually, the LBBP have a better electrical physiology LV synchrony than LVSP, and better LV synchrony than BIVP. The shorter hemodynamic effect might be similar between BIVP and LVSP, But when we see the long-term effect, especially when we focus on the all-cause mortality, maybe the LBBP showed the best long-term clinical outcome, and the LBSP might be worse than BIVP. So that result, I think, may will let me think how to choose the pacing strategy. Okay, that's all. Thank you.